Testing 1 2 test. Test 1 2.
Remote, but we don't need a motion for her because she's not a member. She's just listening in.
Okay. This is the notes, right? All right. Good morning. Calling a meeting to order, and I please ask the secretary to call the roll.
Director Kim? Present. Director Sorrell? Present. Director Stain is absent. Director Webster-Cross? Present. Chair Bott?
Present.
Ms. Merriweather? Present. And for the record, remotely joining us is Director Green.
Great. Thank you.
Good morning, President.
Thank you, Director Green. We appreciate everyone being here today. The next regular meeting is Friday, January 16th at 9 a.m. And asking Secretary, do we have any speakers registered to provide virtual in-person testimony or if sent written testimony to be included in the record?
We did not receive any registrations nor any written testimony.
Thank you. Let's move to our action items. I'd like to ask Dr. Lawrence Smith to present appointments, reappointments to Stroger Department and Division Chairs.
Good morning.
Good morning.
Dr. Lauren Smith, Chief Medical Officer. This morning I have two candidates to present for initial appointment. The first is Dr. Anna Zonkoff for an initial appointment as Chair of the Department of Anesthesia and Pain Management. Dr. Zonkoff attended St. Matthew's University School of Medicine. She completed her fellowship at John H. Stroger Hospital of Cook County and first joined us in 2013. She has served as Associate Chair of Pain Management, Associate Program Director, and as Interim Chair since 2024. The next candidate is Dr. Taruna Pimencha for initial appointment of Chair of the Division of Pain Management. Dr. Pimencha attended Sawa Monson Medical College. She completed an anesthesia residency at John H. Stroger Hospital in 2003, Pain Fellowship 2004, and first joined CCH in 1999.
Thank you, Dr. Smith. Do we have a motion to approve item 3A, one proposed Stroger Hospital Department Chair initial appointment and one Division Chair initial appointment? Motion has been made and seconded. Any discussion on the motion? Hearing none. All in favor of the motion say aye.
Aye.
All opposed say nay. Motion passes. Thank you. And we'll go to our executive medical staff item, EMS of Stroger Hospital and Medical Executive Committee of Providence Hospital reports and action items. So I'd like to have Dr. Bertinatos and Dr. Allegretti. So we have somebody presenting on behalf.
Erin Buckley for Dr. Patronakos to represent the Cook County Stroger medical staff for the HQIP.
Thank you. Good morning.
Good morning. So just a couple notes from the October highlights that were presented from Dr. Gomez for infection control with Dr. Webel. Class C standardized infection ratios are currently at goal at 0.8, and then masking is ongoing and encouraged for the entire system for the viral season. For laboratory, morning labs have been met at goal at 84% for morning lab draws by 7 a.m. And currently near goal for blood culture contaminations at 2.97% with a discussion that there is upcoming federal legislation in HR 5275, which may require us to modify that goal to a 1% goal. In terms of pharmacy, controlled substance audits for Stroger and for Provident have been found to have no diversions, and upcoming metric changes for 2026 will be therefore to remove the CS audits. And then similarly for barcode medication administration, BCMAs, Stroger is at 93% accuracy, Provident at 99%, both at target. And then they will continue to work on medication verification. No further action items were recommended by the EMS for the QPS.
Thank you.
Thank you.
Good morning, everyone. Paul Allegretti from Providence, and I'm here to talk about the appointments and reappointment approval for Providence medical staff. The centralized credentials committee met on November 27th and approved the appointments and reappointments, and this was also approved by the Med Exec Committee on December 5th at Providence, and I'm here to ask for your approval. And I'm here for any questions or comments.
Okay, thank you. Any questions? The motion to approve item 3B. Before I do that, I'd say for the record, Director Harrington has joined remotely as well. Motion to approve item 3B, the proposed Stroger Hospital and Provident Hospital medical staff appointments, reappointments, changes.
So moved. Second.
Motion been made and seconded. Any discussion on the motion? All in favor of the motion say aye.
Aye.
All opposed say nay. Motion passes. Thank you. Go to the minutes of November 14, 2025 QPS Committee Meeting. So these are being presented as presented in the Board of meeting in October. Are there any corrections that are needed for these minutes? Committee. motion to accept item 3C, the Quality and Patient Safety Committee Meeting minutes of November 14, 2025.
So moved. Second.
Motion been made and seconded. Any discussion on the motion? All in favor say, seeing no discussion, all in favor say, of the motion say aye.
Aye.
All opposed? Nay. Motion passes. All right, we'll now go to our reports, or start with our Donna Cox and Kathy for our Sturger Hospital site review. Thank you. Good morning, good to see you both.
Thank you, and good morning. Good morning, directors. Thank you, Chair. So first off, taking a look at the Stroger OpEx dashboard. High level, we have 2 of our measures meeting our stretch goal, 4 of the measures meeting the target, 1 measure that is right at the target, not quite, and 2 that are in the improvement and opportunity phase. Okay. Next slide, please. Thank you. Next slide. Thank you. So first off, looking at our 4 domains: patient experience, clinical outcomes, readmissions, and throughput. Taking a look at our patient experience, we are super excited about all of the work that is being done and where our metrics are lining up. For provider communication, the last 12-month TAPAX still coming in for November at 84.90, and our November TAPAX coming in at 82.26. And we really are excited about our physician leadership, Dr. Ezekoli and Dr. Alanis, for their support and leadership in getting us above our target, well, almost right at our target, and but certainly above our baseline. Also, moving into our nursing communication, the last 12 months through November of 2025 is still at a stretch of 76.12 top box. Year to date, it's better than our stretch at 75.58. November came in at 75.47. This measure is expected to surpass the goal and meet the stretch for 2025. So as you can see, a lot of work being done in our patient experience. Dr. Witten, Ms. Zhang, James Driscoll, and the entire team have contributed to where we are in our nursing experience.
Thank you. I just want to acknowledge, I know that this has been something that the team has been working hard on, so appreciate the work and the progress towards these outcomes and meeting and working to exceed goals. Were there any particular insights from things that additionally that you've learned since we last discussed in terms of what's helped advance this?
You know, I think honestly, it's just the continuing the hardwiring of the nurse rounding and the communication with patients and the training for the physician. It's just continuing to really hardwire.
Thank you.
Okay, moving into our next clinical outcomes. This is where we have really been partnering with our quality team on these metrics. The first one is mortality. The November index is 1. So we came in through October of 2025 at 0.95. So less than 1 in this indicator is good. We are not quite at our organizational goal yet. Much of this is driven by our clinical documentation and coding. And organizationally, we have a lower observed mortality. When our expected is less than our observed, it's, it causes a higher variance. So again, the opportunities lie in our clinical documentation and coding. I will say that the team has included nursing in this. have been a part of the group. Nurse reviewers are looking at, obviously, their documentation. The team has also been working with the Medical Oversight and Surgical Oversight Committee to make improvements in our mortality. And then, most importantly, they've been working with Vizient in looking at the data weekly and also capturing some of the palliative care coding in the last month, and that present on admission for ventilator patients. Looking at our rolling 12-month patient safety indicator, PSI 90, we anticipate that this measure will be close, if not right at the goal. The last 12 months, our composite through October came in at 0.90. October 2025 came in at 0.98 PSI composite, which is better than the baseline. And then again, coding and documentation is incredibly important for that as well. Looking at our sepsis bundle, the measure is likely not meeting the goal, but there is a lot of opportunity. Remember, this is a kind of revamped group, and so they have been working on a lot of the power plans. Those have now been released to the floors, and there's education with family medicine and Department of Medicine. The sepsis leaders have launched education of the order sets, and they're working with the residents on education as well. Moving into our readmission, we expect to meet this goal for the measure in 2025. The last 12 months through November of 2025 came in at 14.9 days for the post-acute hospital visits, and November came in at 13.10 days at the stretch goal. Moving to our COPD rate, we do expect to meet this goal for the COPD readmission. The last 12 months through September came in at 13.02, where our monthly rate is at 17.39 for September. And then our last set of measures, our geometric length of stay. We expect this measure to meet the goal for 2025. The last 12 months average days variance to mean through October, we're still seeing the goal at 1.4 average days to geometric length of stay. And then looking at our ED length of stay for ED discharged patients, we expect again to meet this goal for 2025. The last 12 months through October, the median ED length of stay for ED discharged patients at 296 minutes, meeting the goal. And the October 2025 was at the 280 minutes at the stretch goal.
Any questions, directors? At this time, all right, we'll keep going.
Thank you.
Thank you. Dr. Arnold Turner for Providence Hospital Site Review. Raji, did you want to add anything, or you'll add at the end?
Based on the feedback from the board last month and in the recent months, we are launching an organizational improvement effort around clinical documentation. So, last month, we shared with the board that, clinical documentation CDI work is the common thread that we identify across all of these quality measures. So, it would be a formal PI effort with oversight from system leadership and site leadership, and we hope that effort will help us significantly move the needle on many of these metrics. In addition to that, we are also identifying some model cells for each of the departments, like medicine and surgery, where we identify the most opportunities for improvement. So before we scale the efforts, we would start small. We will address the immediate opportunities we see from our VCN data, and then we go global. That's our plan.
Thank you.
One question. With the sepsis,
Are you finding that the patients come in through the emergency room? Are they also involved in this as well?
Yeah, the emergency room patients are counted in here.
Right.
And, as we mentioned in the past, Ms. Meriwether, the concern we have is not around the quality of the care we are providing, it's around documentation. One of our major areas is around documentation of antibiotics. You see and pulls the data from, the lab data field. Sometimes, that is not correctly reflecting the time the blood culture was drawn. So we are working with, there is a long-term plan, we can enhance the Cerner fields and everything, that's long-term, but in the interim, our IS team has been working with ED to see what else we could do. We are hoping by February, March, we would be able to implement the HIS improvement, opportunity. However, they are working on it. So we are hoping that number would change in the next few months. I know we've been saying that for a couple months, so we hope you would trust us. We are working on it. We're going to get it.
Well, it's part of it is the detection of sepsis, and that is the biggest issue, the early detection.
Correct.
And even in the patients don't know, they've never heard of sepsis. Usually the first time they hear about it is when they have it. And it's not from lack of information, it's just they don't think they have it.
That's very true. In fact, our rates, when we look at how well we treat severe sepsis, it's actually pretty good. When we compare ourselves nationally, our numbers are really good. Even early sepsis detection is not, I wouldn't say it is concerning, but when it comes to documenting all of the bundle elements, we don't do a very good job. And that's an organizational culture we are trying to change. Getting people to document what they are doing, the amazing job that they're doing at the right time. That's our challenge.
Thank you.
Great. Thank you. That was, I was going to follow up on that, but that's this connection between care, documentation of care is excellent and continues to improve, but doesn't always correlate with the documentation. Okay. All right, Dr. Turner. I know you've been waiting patiently. Thank you. Good morning.
Thank you. Dr. Arnold Turner, Chief Hospital Executive, Providence Hospital, Cook County. Good morning, Chair Bott and directors. I want to share with you the results of our efforts with our Operational Excellence Dashboard. On a high level, 83% of our areas of focus are better than baseline, meeting targets or stretch, with some improvements shown. 1 of 6 measures meeting stretch goal. 3 of the 6 measures meeting target, 1 of 6 better than baseline but not quite at target, and 1 of 6 not improving past baseline. Next slide, please. The first one is our increased quality survey volume, return volumes. This is the one that has not, we have not been successful in moving it toward the target. It's going to be below the target. It's, again, below the target this quarter, and it's not going to meet the target for 2025. We only received about 59 return surveys thus far for 2025, and that's below the baseline. Although we have made a lot of efforts in trying to change this number. I know in the future we're supposed to be implementing an email survey, and we'll look to see if that will improve. Because right now, it's just a mail survey, and I think mail is going away like cash, I guess.
Digital.
Yeah. The next metric is nursing communication. November rolling 12 months is coming in at 81.5% top box goal, at the goal. And the November monthly top box was, for communication, was 83.33%, which for the past 2 months, we have met the target. It's been due to a lot of work in our nursing department, led by our Chief Moonen, as far as implementing a strategy to address this, which included hourly rounding, and rounds conducted by the head of that unit also in 8 West. And it looks like it's really paying off, and just want to really raise up the work that they've been doing. The next one is sepsis, and that's the measure that we've shown improvement, but not quite at target. I think the efforts that Raji spoke about are also being applied to Providence. So we look, it's mainly documentation again. We're looking to see in the coming months if we can make that move up the ladder toward that goal. The next one is falls, and I'm very proud of this one. I believe in January of 24, we had 30 falls, and that's why we took this on. And our goal was to, the target goal was to be at 16, and you can see that we're, for the rolling 12 months, we're down to 12, which meets our stretch goal. We've had 0 falls for 2 months, and in September and October, November, we had 1 fall. And that was truly a result of a team effort on the nurses on the med-surg unit. Just want to raise up the entire team up there for the work that they've done to address this. The next one is rolling 12 months for ED decision to admit. For the past, last month we were at our stretch goal, which was at below our stretch goal, which was at 100 minutes. We came in at 95, and we're definitely going to meet this target of being 120, below 120 minutes. And the last one is another measure that we've been doing an outstanding job, and that's left without being seen. Our goal was to be below 2%, and we've been below that as far as the rolling 12 months. And actually, for the past 2 months, we've been below our target of 1%. And that's due to the efforts of both Dr. Alan Reddy, who's the chair of that, head of that division, and Amy O'Malley, who's the nurse manager for that. Just want to raise it up for the outstanding work that they've done in the fiscal year 2025. Are there any questions?
Thank you, Dr. Turner. Any questions?
I was just going to comment that the surveys return, it's the hardest thing for safety net hospitals. They have a great deal of challenges in getting people to return the surveys, even if they're texting or using email. The only one in the Chicago area that seems to hit upon a good approach is Roseland. They tend to have over close to 200 surveys each year. You got to have 100 to have your information. And the thing is, CMS has already started using the information on their website. It's not included in the star rating, but it is reported there. If you have a low amount, they're still reporting that. So, yeah, it is a hard one to address. It really is.
Thank you. All right. Thank you, Dr. Turner. We'll have Craig Williams, who's joining us remotely for ACHN site review.
Good morning. This is Craig Williams, Executive Chief Operating Officer. Can you all hear me okay?
Can. Thank you, Craig.
Great.
Good morning.
Good morning. Thank you. Sorry I'm not there in person today. Let me start with patient experience. So on our patient experience goals, we have 3 measures that we've been working on. The first one is staff work together, which is an important metric for us because when we work with Prescaney, they tell us that movement in this score is going to most help with our overall satisfaction. We have gradual improvement throughout the year, but we're consistently below our target, however, better than baseline. This measure is expected to be better than baseline, but just be slightly under target. In November of 2025, we're at 67.98, which is better than baseline, and year to date, we're at 67.18. We've been making incremental improvements month to month, which is helping our overall 12-month top box, but we know we still have work to do in this area. We recently brought on a new patient experience focused person for our ACHN named Samantha Burke. She's been with us for just over a month, and we're really excited about some of the initiatives that she'll be bringing to bear into FY26. And this will continue to be a goal that we focus on. The next is our talk box care provider addressing concerns and worries. This measure is expected to meet target by the end of the year. We've shown gradual improvement, but we've been consistently below target, but better than baseline. In November of 25, we're excited we met the goal at 68.8 top box. In year to date, we're at 67.24. So with the improvements we've been seeing, we think we will meet target on this goal by the end of the year. And the last one is the care provider explains problem condition. We also expect to meet target by the end of the year. We've seen gradual improvement meeting target with several months at or above our stretch. In November 2025, we met our 69.8 stretch at 69.86 top box, and year to date we're just below 68 at 67.8. And this area has met all of our 4 quarterly expected top box improvements. So on the care provider, really good work, and there's been the MDs and APPs put a lot of focus on that patient experience. The staff working together for us is going to be a really important goal, and that's really from the time someone calls on the phone, how we're treating them on the phone, how they are greeted when they arrive in the practice by our clerks, and that seamless handoff to the back office. So a lot of work under Samantha and the rest of the ACHN leadership team to bring that to bear. The next goals under HEDIS is our breast cancer screening. We are meeting the stretch goal for November of 2025. We came in at 63.5. We've met many of our percentiles set by NCQA on this. We've been doing very well in this measurement, and we're expected to end the year at stretch on breast cancer screening. Hypertension management, we met the goal month to month continuously with November 25 coming in at 58.7. And this goal is expected to meet target by year end. The last metric is around empanelment, and so patients that have been seen in our primary care medical homes over the last 2 years. This we're falling short. I think that's falling short a little bit with an asterisk, and I'll explain that. So November of 2025 is coming in at 117,600 for all patients empaneled. And like I said, this is based on attributed patients to us with at least 1 visit in 2 years. And what we think is playing into this now is that within the last 2 years, we were running the new arrival health clinic. And so all of the 33,000 patients that were seen in the new arrival clinic, if they hadn't maintained care at Cook County Health, that's definitely affecting this number. I think the good news is we have continued to expand our panels over this year, and we're doing a little bit of a deeper dive to understand exactly how the new arrivals have affected this particular goal. But there's definitely is a focus in terms of making sure that we can get new patients in on a timely basis. In fact, this year, through a lot of work, kind of process improvement, we realized a process point where we weren't opening up our schedules to new patients greater than 15 days out. So if someone was calling for a new primary care appointment and there wasn't an open appointment with their provider of choice in the next 15 days, they were asked to call back. And so we've changed that, and we've now expanded that to 30 days, which is allowing us to just to provide a lot more access to patients in a timely manner. I'm happy to answer any questions and follow up.
Thank you, Craig. Any comments, questions? Craig?
Can I add a comment?
Yes.
So, for patient experience domain, if you look at the numbers, 2 out of 3 measures are doing really well. And I know Craig is a perfectionist, but if you look at the first one, the top box, staff worked well together, That is a measure we introduced in 2024. So if you compare our performance to last year this time, we have moved the needle, even though we have not been able to meet our target. So we are making slow but steady progress. So kudos to you, Greg.
Yeah, I appreciate that, Raji. I do think that this is just such an important metric for us, and really, to me, is the thing that captures how the patient feels about their experience and all the work that we put in throughout ACHN to try to make things feel seamless and cut out non-value added pieces of the process, right? So I don't know. I just felt like we would have made a little bit more process improvement this year, but we continue to focus on it. So thank you.
Thanks for adding that, Raji, and thank you, Craig, for you and the patient experience team that work. The other thing on this issue is also that's important is reflecting how we show up as a team in the system, the relationships between connecting people to various care teams and clinicians that they need in specialty referral or follow-up or meeting various needs that come up, and so doing the best we can to meet those needs effectively and appropriately is important. So thank you. And just a lot of great work and improvement demonstrated across Stroger, Provident, and ACHN. So thanks for sharing that. Director Harrington, Director Green, do you have any comments or questions? I want to make sure that, since you're on remotely, if you...
None here. None here.
Great, thanks. All right, thank you, Raji. We'll go to our report on other matters for quality, patient safety, a regulatory update with Joseph Capenas.
Morning.
Good morning.
Here to provide the regulatory updates for December. I want to start with just an update on a previous site visit. We had the College of American Pathologists recertification survey of Provident for lab accreditation took place on October 14th. Plans of correction were submitted, and we did receive full accreditation. So I want to alert the board and group to that. As far as upcoming surveys, I have a number of them. One of them we're well familiar with, IDPH outpatient dialysis recertification survey at Stroger. We're still waiting on this. It's expected at any time, and we've been in the window now just over a year. Also, IDPH EMS resource hospital site survey at Stroger. We're expecting that to take place in the spring of 2026. We've got the National Commission on Correctional Healthcare. This is at CIRMAC for mental health accreditation. We're applying for accreditation with a goal of a 2026 survey, some more to come in the coming months as far as status. We also have the same organization, the National Commission on Correctional Healthcare, also at CIRMAC for jail accreditation. We're due for accreditation in 2026, but we were told it will not occur until after the second quarter or later in 2026. And we also have here ACS, the American College of Surgeons Commission on Cancer, Stroger. This is actually, we already have a date. It's a virtual site visit, again off-site, but virtual, scheduled for April 21st. And lastly, IDPH perinatal redesignation for Stroger, and this is anticipated the fall of 2026. So a number of things coming down the pike. Next slide, please. One of the most important ones is going to be Joint Commission Triennial Prep at Provident. It's unannounced. Again, that being said, we're expecting them likely in the fall of 2026. They did come the beginning of December in 2023. We started deep dive regulatory prep rounds in September, where we rounded on all the units, and we're doing multidisciplinary regulatory rounds now that started in the last couple of weeks on December 4th. So some of the things I want to touch on that are also coming up, we're going to start tracers in January next month. And basically what that means is tracing patients through levels of care, which will include chart review and staff practice as far as anticipating what a surveyor could ask them, where they could navigate to build familiarity and comfort. And then we're also planning a mock survey likely to take place sometime between March and April of 2026. Next slide, please. So I wanted to share with the group some of the things that we're seeing early on, as I put together kind of a top 6 findings during the deep dive rounds that I was completing here. Let's kind of quickly run through them. Again, none of these should be surprising. They're challenge areas at any hospital. We have some expired products which we're able to take care of. Dusty sprinkler or pendant heads. These are for your irrigation as far as fire were to take place. Again, something some people sometimes overlook, expired wall gel. They do have expiration dates on these. As far as hand hygiene, I have been finding sporadic expired preventive maintenance labels. Some logs on the crash carts and eye wash temps that was missing documentation and or they had previous months. And dust buildup. I mentioned the pendant heads, dust buildup on some of the vents. And this is all visual, it's all environmental, but these are the top 6 things I found during my deep dive rounds. So listing those things then moves into what's being done about them. So that's our action plan, the last few bullets down here. So expirables, as far as hand gel, any type of expirables, will we take care of on the spot, so those are taken care of. And again, if it's materials, we'll alert materials so that they can then be replaced. We are looking as far as findings, discussing during weekly rounds, and I send out reports. We've been organizing the findings right now in a spreadsheet so I can assign owners something like pendant heads. That's something that I can't take care of on the spot, but again, we're trying to get owners assigned so that they're aware of it, it can be on their radar, and then they can get that taken care of. And lastly, the next step is that get findings documented in a software tool called Centac, so that follow-up can be completed. We can kind of go full circle and make sure that things are checked off the list. And these are also touch base on the bi-weekly Provident meeting that we've launched a few weeks back, and we'll continue to touch base on. That's what I have as far as regulatory updates, and I'm happy to answer any questions.
Are you seeing any trends or, talking to other hospitals, any trends that the citations are occurring at?
As far as talking to other hospitals?
Yes.
It's going to be interesting because there's so many changes coming in 2026 with the Joint Commission standards. I think it's a little early as far as knowing exactly what those changes, but without speaking with them, I can tell you that the trends I'm seeing just in the top 6 I mentioned are fairly standard. I mean, they're environmental, so there are things that can be corrected, most of them on the spot. But it'll be interesting, and I'll be happy to update this group in the coming months when I start going into chart review, what type of trends I'm seeing there. And that's what I'm really curious about, because that's, again, gaps we want to close, challengers we want to look at. And again, as I mentioned last month, just speaking with staff so I can build familiarity with the questions they ask. I want that comfort level, because staff is very used to going into a chart and charting, but when they have somebody looking over the shoulder asking them, show me this, I want to build that level with them and also make sure that they answer the questions succinctly and don't rattle on so that they give too much information. So it's going to be a education and learning process.
That is so important, because that's where a joint commission catches people.
Sure.
Because they don't feel comfortable, and
Yeah.
they know they were selected to represent the hospital, the unit. And
Absolutely.
it's very challenging.
That gives
so
the
that's a great
yeah.
way. Yeah.
It gives me the opportunity to, again, build that comfort level with them. And since I work for Cook County, putting them at ease and say, let's practice this. We make sure that you feel comfortable in case you happen to be one of the unlucky ones that is called, that you can feel good. We've been through this. I know how to answer this stuff, and let's navigate through it. And hopefully, again, if things work well, they move on quickly and don't do a deeper dive into things. It always opens up opportunity. Any other questions?
Director Harrington, Director
Thank
Green, good. All right, thank you, Joseph. I know Dr. Makaitis was going to add another item in terms of regulatory and the work that the health system is doing to try to get out in front of some of the issues that may impact the care environment and the quality and safety work that the system does. So,
yeah, thank you, Chair. Yeah, we were chatting before the meeting started and thought maybe it would be good to just kind of run through, HR1, the impact, and kind of how we're trying to position to minimize that impact. So, at the risk of kind of being too detailed, there's really 3 main things that HR1 is poised to do. One is happening right now. It's the ACA tax credits going away, Affordable Care Act, Obamacare. That is potentially going to increase out-of-pocket expenses immensely for the folks who are covered under the ACA. And they're anticipating about 35% of them will choose not to re-enroll in coverage. They'll just forgo Medicaid coverage. The next two pieces will come into play in January of 27, and that's work requirements, which basically anybody covered would have to prove up that they are either working or volunteering 80 hours a month or in school full-time. And then the other piece is an increase. So right now, the redetermination process is annual. You have to basically prove up that you're eligible to remain on the rolls. They're going to double that cadence. So when I talk about it, I liken it to basically having to do your taxes twice a year instead of once a year. It's just a lot more, paperwork and burdensome and process oriented and all of that. So in each of those, we're anticipating somewhere in the neighborhood of about 10% loss in each in terms of the covered lives. So that's kind of the threat for the system. If we throw in the question around dish cuts, we're looking at potentially all in about a $400 million loss on the patient service revenue side. So we're roughly $2 billion on the provider side. So $400 million is significant. I mean, that's almost 25%, right, of our revenues. So that's on the financial health system side. Obviously, on the other side of that are the people, right? And as they lose coverage, you see the trends to not engage in care, right? So then you end up with, and this was, I think, where we were talking about, the update about what we're doing and all of that. But, what we'll start to see is instead of people coming to, have their blood pressure or diabetes managed in an office, they'll be showing up 2-3 years down the line with strokes and heart attacks in the ED, unfortunately. So much more expensive, less patient-centered care. So we're taking an intentional shift to kind of pivot into more value-based care thinking, population health, right? So there's a lot of work going on in the ambulatory side to really, and you heard some of it in terms of access and how we're scheduling and all of that to ensure that we're able to get patients in when they need it, but also in that kind of interaction in the care delivery to really think about prevention, focus on annual wellness visits, those types of things. So those operational efficiencies, again, across the board, looking at how we're running our ORs, how we're ensuring that as much access as possible is there. And then externally, well, let me back up. We're also working to try to shore up how we're engaging with other safety nets, right? There's another piece that's playing into this in terms of stresses on the safety net ecosystem. That's the 340B program that's going to change. They're doing 9 pilot meds right now going into January, where basically we'll have to pay full cost and then ask for the money back from the pharmaceutical companies to kind of maintain that discount. So, I mean, it ends up being very much like kind of the payer situation right now where you have to get prior auths or they're denying things without any discussion, and then you got to fight for your money back. So just further stressing, and, where we're probably able to sustain that for a little longer, that ecosystem is not going to be able to. We have systems struggling now because of redetermination starting. We've gone from 13 to 22% just in the last 18 or so months of uninsured, right? The percent of uninsured that's coming to us. That's affecting the smaller safety nets much more deeply, right? So you start layering on 340B and now increasing uninsured, and right, so it's going to destabilize things, right? So we're trying to work to think about how we might partner out. We just approved yesterday some work around neurology and expanding how some of the facilities out in the community we might be able to offer, telestroke and virtual care, both from a patient outcome and stabilizing, the broader ecosystem. That's kind of the thinking there. But beyond that, we've also launched a Medicaid Impact Work Group. So we met, I think it was late September, we had our first kind of big meeting. It was 70, 80 people in the room, and it was not just providers, health plans, public health departments, HFS, DHS were there. And then we also had, business leadership, technology leadership, academia. So really trying to think about how we can mitigate that impact more globally, not just how do we as a health system brace our impact, but how do the broader community. And there's been a lot of interest in kind of what those action items might look like. The first thing that came out was how we're communicating in a standardized way. Everyone's kind of having to make it up for their dedicated patient populations, right? So like if they're going to somewhere in the Southland or somewhere in the south suburbs, right? Those are south side of Chicago, those hospitals are just figuring it out, as are we, and everybody's kind of, so one of the things is how do we lock elbows and have a, more of a playbook around communication. And some of the community organizations that were there shared anecdotally that people are already foregoing their coverage because they think the cuts are in place and they're just not going to have coverage. So they're already not re-enrolling, even though they could still have coverage, right? So, I mean, there's impact now, just because of the narrative, right? So, so talking through how we minimize that, but then also as we go into those, you know, the kind of the impact period where, you know, now ACA next year, work requirements and all of that, right? How do we continue to make sure that we're unified in the messaging as a broader organization? And then, working with the health plans, you know, County Care has done a phenomenal job in keeping their, the folks up for re-enrollment every month. It's kind of a rolling monthly re-enrollment. And, you know, they're north of 90% usually every month of retained lives on the roll. And the state average is somewhere in the low 70s, which means some of the health plans are much below 70%. So it's getting the health plans into a conversation about, again, how do we standardize a playbook where we're all kind of doing the best practices and ensuring that, you know, we're maintaining the roles, again, trying to mitigate the impact and minimize uninsured lives. And then to the, very much to the president's credit, she has started a very similar conversation through counties. We had in October, we met with Hennepin and Harris counties at the large urban caucus meeting up in Milwaukee, and she brought, you know, some of the health system folks into the conversation as well. And then, so February, there's going to be a national meeting for the National Association of Counties, so that'll be many, many more counties coming together. So really looking to kind of broaden the tent there. And I think the conversation there is really to ensure people understand what this impact is going to potentially be. And what I found interesting is they shared some information at that meeting in Milwaukee that red states and counties will actually be more impacted than blue states and counties by the Medicaid changes. So it's trying to find a way to reach across the aisle and have that conversation so we're all aligned in understanding what's about to happen, and that, you know, maybe we can turn the volume up a little bit by having that, you know, that consensus, right, and showing that alignment. Similarly, through the work group, we're also trying to think about how we're engaging various stakeholders and finding the right lens to kind of explain that to each of the groups, right? So the business leadership community, right, understanding that Commonwealth Fund is talking about 600,000 lives losing coverage in Illinois over the next, I think, 10 years, 2.5 billion out of the GDP, right? I mean, there's, you know, and then what happens, you know, how are we engaging chambers of commerce, right, through the business community so that they can understand as these small hospitals close, a lot of times they're the economic engine for that local neighborhood or that town or whatever, right? So, what's the skin in the game for the business community and through that conversation, right? And how do we activate them as well? Same thing with the unions, right? How do we have that conversation around headcount decreasing by people leaving the workforce, right? So kind of looking for all those different angles. So multiple fronts, a lot of work to do, obviously, still, but, you know, that's some of the things that we're trying to do to, you know, engage the community and mitigate the impact. So.
Just a quick question. Yeah. You mentioned the impact work group, include HFS and, you know, county care and everything. So are they actually tracking actual numbers with Medicaid?
In what meaning, like people?
Like number of people dropping out?
Yeah. So we do for county care, absolutely. How many lives we're losing, right? So we're just under 400,000 now, but we had started, I think we were like 460 about a year ago.
I think that the ACA is going to have a huge impact on delayed treatment, which then a year, it could be even sooner, hits people. I also wondered if, with the community organizations, one of the things I found especially in the south side and west side of Chicago, is the faith-based organizations play a key role. So having them at the table will also help to turn up the heat. I serve on a committee with Congressman Jackson. So I think it's on their radar. It's on their radar, and the faith-based are really, they want to be engaged and involved because this is important to their community.
Absolutely, and I think making sure people understand the impact is key. You know, we went, a few of us with the president and kind of the medical leadership team, the commissioners, Lowry and Benaya. We were in DC, and we actually met with all but one of the Congress people who have districts that cover Cook County. And so both senators and I think 11 of the 13 we met with in person. And it was interesting just getting into the details with them and raising that awareness and really getting them to understand, like, this is, at least for our health system, we did it through the lens of our health system and the impact to us. Hearing those numbers, I think, was eye-opening for almost all of them. They didn't, I don't think, realize the full, like, just what's at risk. So,
With the recertification, does that have to be done in person?
no.
Okay,
Yeah, we put teams out, County Care does,
okay.
and there's also a, phone campaign. I mean, it's
Yeah,
multi-pronged.
that's
trying to
what
keep
I was
people involved
wondering.
in digital phone.
Yeah, because it's hard to bring people into offices.
It is.
And now having to do it twice yearly versus once.
Yes.
Right.
The once was problematic enough. But it sounds like even with just the 10% potential attrition that you were seeing, that actually was more encouraging than what I was.
I think that's over and above the losses we're seeing now.
Okay.
It's actually going to accelerate by that much more.
Right.
So, unfortunately.
What are some of the supports that you're looking at being able to shore up for population-based health and through the public health department to be able to try to keep that messaging then going to the community?
Yeah, so it's very much, we're thinking internally about how, so we have kind of three legs of the organization, right? It's County Care, the plan, right? The DPH, and then the provider arm. And we've really been doing a lot of work about how we kind of cross-pollinate between those three, and how does public health, to your point, get out in the community and raise that awareness? How do we then use them to funnel into the provider side, right? So we're working through all of that right now. Right now it's been very much internally focused on the provider side, on how we ensure enough access and how we're functioning, efficiently enough so that we can, make sure people are able to get in for the care they need. And then on the plan side, I think it's much more about how do we focus them externally so that the other plans, if they're willing to engage in the conversation, can look at what, how do we come to best practice to make sure that the fewest lives are lost right off the rolls.
Have you been able to meet with the other plans?
Yeah, we had a handful at that meeting. Yeah, they were.
See how you can kind of shore up numbers across the board? It sounds like their recertification rate is somewhat less.
Lower, yeah.
That's going to be an additional issue across the continuum.
We had a handful in the conversation. We're also, HFS has been a really good partner in terms of, help us create kind of a playbook, and then obviously they'd have to approve it. So we're kind of in those steps of, like, how do we kind of create something for them to react to, and kind of getting everybody at the table. But yeah, the health plans it'll probably be a spun off work group out of the bigger kind of, so right now there's kind of a comms work group, and then interestingly, we had academia in the room at the big meeting, and a gentleman from Northwestern came over and said, well, we did a get out the vote initiative a couple of years ago with some of our more civic-minded student body, and they're like, this isn't that different. I mean, even if it's just communicating, he went so far as to say if HFS is willing to train some of them, maybe they could even help with some of the re-enrollment process too. So, so really trying to get fresh eyes on the problem and think about, a little bit out-of-box thinking with people who maybe aren't just steeped in healthcare.
So you mentioned that you've been tracking numbers, right? So where are these, are there particular areas or population groups that have been infected more? Like, are there locations or population groups you're targeting to intervene?
Yeah, I mean, it's the Medicaid covered lives, right, that we're concerned about.
I understand, but like, are there particular locations that let's say if you want to deploy students or, some kind of outreach and with CBO, like, do you know, like, what community, which community area?
Yeah, so we're working through that. So HFS and Department of Insurance they have like a zip code heat map of where, I think DOI can get to like which product they have, so we could more laser target ACA, Medicaid covered lives. But yeah, so we are working on where the need is good, or where the impact is potentially going to be needed. So.
That would be really interesting to see, because I know that CBOs are like very concerned about the impact coming down, so they're also like ready to like collaborate.
Yeah.
So,
How about, do you have the FQHCs, the
Yeah, they were in
community?
the room.
Because they're very concerned, very concerned.
Yeah, they were in the room with us. Yep.
That's a big room.
It was like 70 or 80 people. It was really good.
That's good.
And then I've had the incredible opportunity to speak at a few, panels, and we've, Alex and team, actually created a little, it's almost like a note card, like a 3x5, just explaining what it is with the QR code on how to register. So we've actually gained additional interest through having those kind of external facing.
So it's great. It's also this kind of effort, of trying to meet people where they're at, where they live their lives, and try to engage them also in the system and in the ER and the clinic, to remind them of the need to do this and where they can find more information. So thanks, Dr. McCudis. Appreciate the additional information and how it relates. Before I close here, because the committee won't be going into closed session, I just want us to really join me in a round of applause for just the incredible work of this team all year on quality, safety, patient experience, working across different parts of the system, as Dr. McCudis just alluded to really try to show up in the best way we can for our community, for the patients we serve. And so it takes a team, and so I just want to give the team a round of applause for their work. And look forward to the continued work on improvement and maintaining things that we're doing well, and we're here to support and help however we can. Anything else from the directors before we close here? Okay. So the agenda is exhausted. I declare the meeting adjourned.